So while we're waiting for the folks to log on, is there any particular area that you want to start first between SLE or RA or MS? Because those are the last three concepts or exemplars. No specific area?
Ms. Edson?
Yeah, there we go.
This is not related to the SLE or MS. Can I ask a different question though?
Sure.
In regards to the testing, I'm assuming that we're going to have a math test. And I was wondering, are we able to use a scratch paper? Because usually on conversion, I write down my meters or whatever conversion that I have.
So ExamSoft will provide you with a whiteboard, but you cannot physically have any papers because the exam doesn't allow for resources, which means there's no notes, there's no scratch paper. The scratch paper is built inside the test with the whiteboard.
Okay, thank you.
You are welcome. Any other questions? Just to make sure, I hope that everyone actually signed or did the test. Otherwise, when you get ready to take the test on Monday or Tuesday, for those that have clinical on Monday, then you're going to have some difficulty because it's going to chew into your time of making sure that you are on. So if you have not done the practice exam, then you may be held up in trying to get that completed. So if you are having issues, then make sure you contact ExamSoft so they can help you, if you know, to make sure that your computer's okay and they can navigate you through what you need to do. All right, I'm going to go ahead and start. So I need a starting point though. So where would you guys like to go?
Lupus.
All right, lupus it be. So let's start with what is systemic lupus erythematosus? What is that? What does it all entail? You can't hear anything? Can you hear now? Because I'm not muted, so I'm just wondering. And I purposely made sure that my camera actually just had a photo versus using a video footage line or however you want to put it. Working now? Okay. How about you, Ricky? All right, it is. Are you getting it? Is it better? Perfect. All right, we got them on. Perfect. You're welcome. Okay, so lupus is an autoimmune disease, but how does that come about? What precipitates this process? So I'm going to do two things. I'm going to hit record. That's going to be very important. And then two, I'm going to share my screen. I'm just waiting for, let me try that again. The body attacks its own cells, okay? Overproduction of the B lymphocyte stimulator cells, that's true. All of those things are true. The question is, how does all of that happen? And that's going to be our focus. So that way we understand what's happening with these B lymphocytes and how they play a role. So with that being said, I'm sharing my screen. You should see the whiteboard. So yes, the cells do attack themselves. They do not recognize that the cells that are there belong to them. But what ends up happening is that you have a person that may have sensitive or sensitivity. So if they have sensitivity, then they may have something called a sensitivity gene. So this individual will now be susceptible to getting lupus because they have a susceptibility or sensitivity gene. And one cause of lupus, is just one of many. One cause of lupus is UV radiation, so sunlight. So when this person is exposed to sunlight, then if they have enough sunlight exposure, the cells of the DNA can now become damaged. So this makes the cells or damage the cells. So what ends up happening is that the cell undergoes what they call cellular death, and it now produces apoptosis. So here you can have a cell. So here's your cell, your nucleus, da da da. And then now this cell will become like in several pieces. And then you have your nucleus material that is like now out and available. So when that happens, then the apoptotic bodies, or these tiny little pieces, and this here is apoptosis. All of these 4 pieces here. And now it exposes the inside of the cell. So this material here, this was the inside of the cell, the nucleus included. And so now those things are exposed, the DNA, the histones, the other proteins, and it now becomes exposed to the rest of the body. So this susceptibility gene affects, that it has effects on the genes or the person. It now makes it susceptible to the antibodies, not recognizing it as itself. So their immune cells start thinking, hey, this stuff, this foreign substance, although it really is their own, doesn't belong to us. So this is what they would now call the nuclear antigen. Once all of the insides are exposed. The other thing that happens is that your susceptibility gene can't clear. So once these cells break down or apoptosis occurs, then it cannot clear it and it cannot eliminate those bodies. So therefore you end up with increased antigens in the body system. So you have a decrease in clearance and you now end up with more of the nuclear antigen. Once that happens, all these nuclear antigens are floating around, and then your B cells, which someone mentioned in the chat that the B cell lymphocyte stimulators are now available. So now these B cells that are floating around will see this exposed material and think of it as not being itself, and then build up antibodies to the nuclear antigen. So now we have the presence of the anti-nuclear antibodies. So that's how that process starts. And then you end up with antigen antibody complex reaction that happens from that. Then it gets into the bloodstream. Once it's in the bloodstream, then it can either deposit itself on, other organs and tissues, or it can stick to the vessel wall and the kidneys, the skin, the joint, the heart. It could be in several different areas. So once it's deposited, then the inflammatory process begins. And so it causes damage to, damage to that area via the complement system being activated. But on the cells of and tissues of the organs that it affects, it's going to leave the membrane dysfunctional. And what I mean by dysfunctional, so once it travels to another area, so say it goes to the kidneys, which is one location it could go, the cell membrane that would normally be whole, now the cell membrane has openings on the cell membrane. So now fluids can go in and out of the cell freely. So it makes it more permeable. So now we have fluids that can come in, fluids that can go out, and it's nothing that can control it one way or the other. So any fluid is free to go in and out of the cell. And now the cell becomes damaged or the tissue becomes damaged. What type of hypersensitivity is that known as? Type 3, correct, Jessica. So this is known as type 3 hypersensitivity. So we don't want this to happen in healthy tissue or healthy cells. But if you had a foreign substance or if you had an infection or an infected cell, you do want this to happen. So basically, it's happening to healthy tissue when there's no actual cause for it to happen. Other things that can trigger this process could be smoking, it could be viruses, it could be bacteria, certain medications, estrogen, um, isoniazid, which is what we talked about in TB, hydralazine, they use that a lot to help with management of blood pressure. So those types of medications can also trigger this process. Who tends to get this more and when? Do men get it more than women? Do women get it more than men? Is it the elderly, the children, people in their reproductive years? Who gets it more? Women get it 10 times more than men. So it's more common in women than in men, 10 times greater in during their reproductive years. Whereas women still get it more than men, but the level of how they get it is less. It's 2 to 3 times more common um, in women and men compared to their childhood or if they're over 65, which is known as their non-reproductive years. So there's type 2 hypersensitivity. What is type 2 hypersensitivity? So type 2. Oops. What is type 2? When does that occur? Okay. Give me an example. We got allergy. So type 2 develops when they target other cells like your red blood cells and your white blood cells or the phospholipids. So when those areas are attacked, then that causes phagocytosis, and that destruction will lead to additional symptoms. So what the other signs or other sign or symptom related to SLE, if based on your book, talked about um, the blood cells, right? Besides the skin lesions. Right. What specific DNA or what lab value is very specific to lupus? So ANA can be used in any of the autoimmune diseases, but there are two that are pinpoint specific to lupus, and one is the DS DNA. What's the other? There's going to be the anti DNA and the anti Smith. Not that ANA is not used to actually check, but it is. But the two that's pinpoint specific to lupus are going to be the anti, and DS stands for double-stranded DNA, and then anti-Smith. And those are primarily found, the anti-Smith targets the ribonucleic protein, and the anti-DNA or double-stranded would be seen during the active disease. So once the disease is active, then it's more visible. So you still can have, use your ANA that lets you know that there's some type of autoimmune problem. You still have your C-reactive protein that still lets you know that, we have an issue there. And it's not clearly easy to diagnose. It's difficult to diagnose because of the various portions of the body that it can affect, and it affects people differently. So two people can have SLE, but they will not have the same signs and symptoms. So there's some criteria that would help us understand that this may be SLE. And your book outlines that they need to have so many of the symptoms, right? What would be the symptoms they would need to have? So you need to have 4 or more of some of the immunologic symptoms, and they gave you the mnemonic SOAP brand MD. So you have the rashes, that's the first one, and you can have a malar rash, and the malar rash is that butterfly rash that you normally get over the cheeks and around the nose, and that's when they've been exposed to sun. So let me clear that so we can outline these symptoms. All right, so they need to have at least 4 or more greater than or equal to 4 out of 11. Okay, and so of the 4, they would look at the rashes. So They could have the malar, the discoid, pardon me, I had to move over my whiteboard. It was sliding off my box. Besides the rashes, what else would we be looking at? They can have they can have ulcers, right? Somebody wrote that. So we can have rashes, we can have ulcers, and those ulcers can be they're going to be either in the nose or the mouth. They can have the mucosa that's affected. That's what that would be from here. Then that's the inner layer. The outer layer is the serosa. So they end up with serositis. So that would be, if it happened to like the lungs, then they would have pleuritis. Or they could, if it happened to the heart, then that could be pericarditis. Okay. We have the joints that can be affected. And we need at least 2 or more joints to be a part of that, to be considered potentially lupus. And so that would be another concern. So usually they have some type of arthritis in those joints. We also have the kidneys that can play a role in that as well. Somebody posted that in the chat. And usually with the kidneys, they're going to have an abnormal urine protein. And they may also have, difficulty, or not difficulty, but diffuse proliferative glomerular nephritis. Get that S on there. There we go. So that's another issue that can happen. Photosensitivity, we talked about that earlier, but it definitely bears bringing up because that's how those skin lesions, some of those come along. So photosensitivity. Oop, there we go. We also have the brain that can be affected. And so the signs and symptoms that you would see in the brain would be seizures and psychosis. So from a neuro standpoint. We also had the blood. And with the blood, and that's where that secondary hypersensitivity came from, they can have anemia, leukopenia, thrombocytopenia. Then the last one would be the antibodies. And there was a couple, because those antibodies, they can cause several issues, especially if it's in the heart. They can end up with, if it's in the heart, they can end up with endocarditis, myocarditis. So end up with vegetation on the valves, the mitral valve, which would be part of that endocarditis. So there's a lot of different presentations, but they would have to have at least four or more of those in order for them to diagnose with lupus, in addition to the lab values and things of that nature. So there's um, quite a bit of things to actually look at. So although the anti-nuclear antibody, which is a large portion of the patients they have, but they also have that in other autoimmune diseases. That was the ANA. So if you have this, and I'm going to clear screen here and look at lab values. So the labs, we talked about the ANA, but that's, it would be positive or elevated, but it's not specific. We talked about the C-reactive protein, and wasn't there a SED rate? Would that be true? The sedimentation rate? Yeah. So the erythrocyte sedimentation rate, either one of those. The complement system, so complement 3 and 4. And they actually would be decreased in the active disease. And then I talked about the specific ones, which was the anti-double-stranded DNA and then the anti-Smith. Rh factor would be positive, and your Rh factor are proteins from the immune system that attack healthy tissue. So we'd have a positive Rh factor or a rheumatoid factor. We just call it the right word so we don't confuse anything. So quite a bit. So lupus is just one of those conditions where you can't say it's specifically from this, or this. Generally their presentation will be fever, weight loss, and then they'll have one of those rashes, whether it's discoid or malar, primarily malar, and then they'll have some joint pain. So that's usually the most classic signs and symptoms that you will see. If you get to specifics, if it's like in the kidneys, then you're going to have you'll have issues with the kidneys, oliguria or urinary frequency, some type of complaint there. So it depends on the organ that's going to determine if it's going to be a specific area that may be affected. Lymph nodes will be enlarged. They could have splenomegaly. So those are some additional signs and symptoms that the patient may experience with SLE. So chest x-ray or CT scan of the throat, because they're looking for, if they have, not the throat, the thorax, if they have any, that pleuritis that I talked about before. So if it's there, or pneuma or pneumonia, that would be another issue. They may do some type of cardiac imaging to look at if they have endocarditis or myocarditis. Diagnostic procedures would be, depending if it's any organ involvement, then it would be geared towards that, whether it's the kidneys or whether it was the brain, then they would do diagnostic studies related to the brain to see what kind of functionality it still has. So overall, things that we need to look at for treatment is basically manage the symptoms that the person has. So, some people can have lupus and it may not, it may not distort their skin or anything like that terribly. Or it may be all internal. So it's kind of hard to say, they're going to develop one thing one way or the other. But we're going to, if it does affect the kidneys, we need to look at potentially kidney failure, maybe needing dialysis. But we're going to talk about, how much exposure to the sun they may have. Let's minimize some of these environmental factors that have been associated with SLE. reducing stress, looking at potential for clot formation, because if they have the antiphospholipid syndrome, then they're more prone to more clots. So they can develop deep vein thrombosis, they can develop a hepatic vein thrombosis, they could have a stroke. So our treatment goals is more to prevent the exacerbations and to limit the severity of the exacerbations once it's gone in action. Some other things for diet, it depends on the person's situation. So we're going to try to make sure they have a balanced diet. And then we do restrictions based on, the organs and tissues that may be involved. So if they have hyperlipidemia, then we're going to be looking more at a low fat diet. If they have kidney involvement, then we're going to be looking more at a low protein diet. Um, Considering vitamin K intake, so looking at foods that may be high in vitamin K, for somebody that may be on Coumadin therapy to prevent clots. So we need to talk about the green leafy vegetables, the cabbage, the broccoli, blackberries. Those will all be things that are rich in vitamin K for the individual to take. And that wouldn't be across the board for all patients unless they actually have those conditions. But auscultating lung sounds, looking at joints and seeing if they're painful and stiff and all of that, and think about heat packs. Talk about exercising, and should they do like high intensity impact exercises if they have SLE. High intensity, so like high aerobics, would that be gentle for the joints? So no, we don't want to have them do anything like that. So swimming would be really good. That'd be a great thing to do to help with joint movement. Other things to consider, safety measures, because of the fact that they're at risk for injury and they may have neurovascular dysfunction. So at regular exercises, range of motion exercises, which would be good. We want to prevent contractures, support their self-image, investigate what type of coping strategies they use to help, minimize stress, will be things that we want to also educate the patient about. So what if you're not really sure of what types of exercises or what type of diet your patient should have? Who could you enlist to help you with that? Dietitian for the food part, for sure. What about exercises? PT and OT. So physical therapy can help you with that component and really help the patient. So overall, this is going to be a multidisciplinary approach. You need a physical therapist, you need a rheumatologist, you need a nutritionist. They may need some case management to help assist at home. So some patients have spontaneous permanent remission. Some people continue to have exacerbations and flare-ups. So, they need to be as active as possible using sunscreen of at least 50 or above. When you are caring for these folks, you want to make sure that you kind of cluster your care too. Talk about using heat to kind of get your joints a little bit more loose and less stiff. Looking at body alignment techniques and posture techniques, the importance of following the appropriate diet and taking their medications as assigned. And what medications can we use to treat SLE? Steroids, for sure. Your prednisones, your dexamethasones, but they're going to primarily be on prednisone or methylprednisolone. So someone said monoclonal antibodies. What is a monoclonal antibody? Okay. So how does that work? It's an immunosuppressant. So belimumab, it helps to suppress the B lymphocytes. Okay, I like that. So it does prevent the B lymphocyte stimulator from actually surviving and producing antibodies. So that's what it's going to do there. Your non-steroidals like your ibuprofen for minor arthritis and fever, or aspirin. And then we have Paquinil, or the hydrochloroquine that someone talked about. That's actually an anti-malarial. But why do they use that for SLE? Why are we using an anti-malarial for SLE? Okay, I can go with suppression of the inflammatory. It has anti-inflammatory properties, so that's why they use the Paquinil or the hydroxychloroquine. It has a category C for pregnancy, so they do ward against using it if you're breastfeeding or the mother's breastfeeding, or if they're pregnant. They're not really sure exactly how it affects the fetus or the baby, but they will only use it in those instances if the benefits outweigh the risk. So just kind of FYI on that. Any corticosteroid, it would, if the person's under stress, should they consider increasing their corticosteroids? Talk to their physician about that. Yes or no? The answer to that is yes, they should. So it's not just for specific conditions. Anytime you're on those corticosteroids, glucocorticoids, prednisone, things of that nature, under stress, the utilization of that medication goes down. So they should at least bring that forth to their physician, or the physician should really bring it forth to the patient that under stressful situations, you will probably need to increase your dose, and then talk about what dose they should go up to. We also have methotrexate, and to help with the arthritis and the rashes and things like that. If there is kidney involvement or central nervous system involvement, then the cyclophosphamide may be used. So, when you're reading the test questions, yes, and then titrate it back down. That is true, Tramika. Thank you. When you are looking at test questions and you're trying to break down the test question, if it doesn't mention, a kidney issue, or saying the patient has kidney involvement, or that the patient has central nervous system involvement, then answer the question based on the information presented. If it's asking you, what things would be appropriate in the plan of care, well, then all of those things would be appropriate in the plan of care, because it's not saying that we're not speaking about a specific patient. We're now just asking what would be appropriate in treating somebody with SLE. So does that make sense? There's a slight difference in the verbiage, and it is semantics, but just kind of think of, if we're looking at the overall plan, what interventions could we do, then that would be fair game. Um, Other things like to treat their hyperlipidemia would be their statin medication, so they would need to do that, and then consider some type of coagulation modifying medication for the management of clot formation, especially if they have the antiphospholipid syndrome. So that's going to be very important there. One last thing, who can describe for me plasmapheresis? Because that's another option that they can receive. Plasmapheresis. What is that? Because under stress, it would not be effective. And we are trying to minimize the steroids. It's not so much about the immune system, more so than the inflammation. So we need it to be available for that person to reduce the inflammatory process. If it's not being utilized appropriately, then we don't have what we need to help. Does that make sense, Ricky? When under stress, any stress. So that's why the conversation needs, the physician should be having that conversation with those patients. Um, are DMARDs recommended for SLE? Yes or no? Okay, which one? Mm-hmm. So that'd be your IV immune globulin, right? Perfect. Okay. We already talked about the hydroxychloroquine, which is an anti-malarial, and that, Jessica, would be the how it works in lupus, and it's used for dermal lupus, is it has its anti-inflammatory process. No, hydroxychloroquine is an anti-malarial. So what you guys will learn is that you have medications like hydroxychloroquine that can be used for more than one condition. So there's some crossover in medication usage that you will see. All right, back to plasmapheresis, because we kind of lost. There's been some commenting on it, but then we had some other questions come through, or other statements come through, and questions. So here they're going to basically kind of clean the plasma of its of the antibodies or the bodies to prevent healthy tissue attack. So the plasma is separated from the blood. So spin it down, and either they're going to replace the plasma with saline or albumin, or they're going to treat the plasma and then put it back into the body system. So that's what plasmapheresis is. Whether it's, someone else's or yours or however, that's what they're going to do. So it's basically a kind of replacing the plasma replacement. So we're going to get rid of the plasma that's holding on to the antibodies that's causing the body to attack itself, and then replace it with either saline or albumin, or we're going to replace it with treat it and then replace it back into the body system. So we have a couple of options there that we can use with the plasmapheresis. Okay. Any other questions or comments about SLE? All right. So let's look at RA, which is another immunity concern, and it's also another autoimmune condition. And so primarily rheumatoid arthritis is going to attack joints. It can go to other places. So you can have skin, you can have heart and lung involvement, but usually the issue with RA is that it's in the joints, or in the joints only, like the synovial tissue or the synovial fluid. So how does that all come into being? What is the the pathology or the pathophysiology behind RA. Because what's happening is we have inflamed synovial tissue, and it can affect all weight bearing joints. So, just like SLE, there's no cure, just like SLE, they're autoimmune. And the earlier you catch it, the better the treatment methodology is. It's another one that's difficult to diagnose. Um, what I would say in reference to, Kristen, to hydroxychloroquine, I would say that although they do not have research on humans to say that this can affect the pregnancy, the physician may or may not decide to give it. And, that would be up to the physician. And, they don't know exactly how it affects the fetus, or if you nurse the baby, how it's going to affect the baby. And then they would have to make that decision together. But I would not guarantee them that it's okay for pregnancy, because in that rare instance, that person's baby or fetus ends up suffering. And even if it wasn't related to the hydroxychloroquine, the patient may associate it with that. So, you know, I would just give them exactly what a category C is and what that means. And although they haven't seen it in humans, I can't say that it's not, and that would be a true statement. Okay, you're welcome. All right, so we have a lot of stuff happening here. So I got to get caught up. Okay, so yes. So the first thing that happens is the synovium becomes inflamed. So we have inflammatory process that kicks in. And our white blood cells go there, and they're actually going to cause the membrane of that synovium to become inflamed and thickened. So over time, you're gonna over time it will cause the bones and the cartilage to erode. So the in that whole area, and we're gonna say, for instance, the knee, because this is kind of a common area, and then that will lead to the next stage. So the first stage is that you have synovitis, which is inflammation of the synovium. So the inflammation from stage one is now going to create something called a pannus, which is fibrous tissue. It's a layer of fibrous tissue that is surrounding that area of the joint that damages the bone and the cartilage within that joint space. So the space in between the joint begins to disappear, and then it progresses to stage three. So the cushion that the individual had is no longer there, and now the two bones will end up fusing together. What's that fusion called? What is that fusion of the two bones called? Correct. It is called ankylosis. So once you have ankylosis, which where both of the bones will fuse together, this causes the stiffness and the inability for the joint to be mobile. So now the joint is still inflamed, and it erodes to the joint cartilage and the bones, causing the phalanges to curve outward. That's how it affects the fingers. So the book gives a very good description of, the joint, and that usually happens in the later stages, but all joints can be affected systematically. It can also look at the heart, the skin, the lungs, and also the blood. So there is, tell me about the abnormal finger process. So the joints closest to the fingertip is permanently bent toward the palm, whereas the joints closer to the palm is bent away from it, right? Kind of known as the swan neck deformity. When you palpate the joints, how would they feel? Yeah, swan, NECK, swan neck deformity. So when you palpate on assessment, how is it going to feel? Very spongy, soft, um, swollen, tender. It's going to be kind of boggy. Okay. All right. So does, yep, ulnar deviation, which we talked about the fingertips. That is true. Um, some causes. What are some causes that could be related to SLE? What's the reason why people, I mean, not SLE, rheumatoid arthritis? What's the, okay, smoking. Most of it's insidious though, right? So, we do want to look at, do they smoke? Those would be some indications, family history, but primarily it's idiopathic. We don't know why. All right, hang on one second. My computer's about to die. I got to run and get the cord. Hold on one second. Sorry about that. All right, sorry about that. I just didn't want to make a whole bunch of commotion while I was putting this plug and stuff in and moving around. Okay, so family history. It's also been linked to hormonal factors, bacterial and viral infections. So those are some additional causes that could lead to RA. Primarily, what gender is affected? Women. Yep. Okay. So, uh, what else is there? What type of environmental exposures? Okay. Someone goes, always women. Yeah, it's unfortunate. Okay, so the two common areas where you will see RA is going to be in the fingers and the wrist. So we've already talked about the softness, sponginess thereof. Some of it can still go to neck, shoulder, elbows, knees, ankles, and feet. It can happen at any age. And they're going to have a lot of mobility dysfunction. Laboratory test. And then we'll look at signs and symptoms here. I'll share my screen. So what type of laboratory test? So we know the rheumatoid factor, correct, is usually positive in 75% of the folks. And how do you know it's positive? What would the result show? If you're saying it's positive, would it be high? Would it be low? It'd be, okay, SED rate will be increased. It'd be high. So let's kind of group them all together. So let's share screen. Okay, so with that being said, minimize that here. You're going to have positive rheumatoid factor, right? And these are labs. And remember, the ANA is going to be positive, but it was also positive in SLE. So that's, just let you know there's an autoimmune problem here. All right, then we also have the C3 and complement 3 and 4. Again, they showed up in SLE as well. And they're going to be increased. Okay. SED rate. And it's going to be elevated, as well as C-reactive protein. And it's going to be as well increased. So we have a lot of different lab tests that we use, and some of them cross over to other autoimmune diseases. Okay. So the reason why, the C3 and 4 here would be increased is because of the synovial fluid. It's going to be very turbid and it's going to have a little, or the viscosity is going to be decreased. But our CBC, we're looking for our white cell count. And we're also going to look at our RBCs, because we're going to be looking at anemia here. But the WBC is going to be elevated, as well as the platelet count. So we're going to be looking at the platelets, but it's going to be elevated as well. Okay. So we can do for diagnostic studies, so diagnostic tools, we can do an MRI or CT scan. We can do either one of those two to look at the extent of the damage. We can look at x-rays earlier on to see if there's any, demineralization. And swelling. So as time goes on, you could actually see if there's any type of erosions to the bone. You can do an arthrography, an ultrasound. Those are all options. You can do a bone scan to see if you have aseptic necrosis. So there's several different things that we can do to look at, kind of diagnosing RA. So what does the American College of Rheumatology say? What do they use? What is their criteria that they use to diagnose RA? Four out of 7 symptoms, okay? So they also look at people having a joint or with synovitis or swelling that they can't explain. So they're looking at joint involvement, they're looking at serologies, they're looking at the acute phase reactants. So all of those, how long it's lasts. So less than 6 weeks, greater than 6 weeks, and they're providing a score. So they're looking at joint involvement. So if it's a large joint, two large joints, um, or 10 large joints or three small joints. So the book outlined a clear path. Just understand that there's going to be three things they're going to focus on, or four things: joint involvement, if they have any rheumatoid factors or citrulated protein antibodies, if they have any acute phase reactants, so sed rate or CRP is elevated. So there's criteria that they use, and it's not the same as SLE, but you still need to, those things would need to be present. But then they're looking at a score. If the score is 6 or higher of the possible 10, then they're looking at the person having rheumatoid arthritis. Lower scores, then they would reassess them to see if they may develop rheumatoid arthritis. So focus of our management should basically be on preserving the joints, doing patient education related to the medications and the importance thereof, checking the patient's mental status, because if they do develop those contractures, especially the swan neck deformities to the hands, that's going to be a body image alteration problem. So they tend to have self-esteem issues, depression issues. These are life-altering conditions, and that leads them with a lot of limitations to just basic life, daily life activities. So brushing their teeth, combing their hair, putting their clothes on, something as simple as buttoning up a shirt or zipping up a pant. So that's going to be some huge changes for an individual that develops RA, and the fact that there is no cure. So that's going to be profound. Other things we can have them do for treatment, they can use, moist superficial heat, cold applications when the joints are inflamed, paraffin treatments. They could use assistive devices. So again, we're going to need OT and PT because they may need orthotics, they may need a walker, they may need a cane, they may need those grabbers that they could use to get things that are far away. So they're going to need some additional pieces so that way they can continue to maintain as much joint function as possible, and then working on stress relief. So how to manage the flare-ups is basically resting the joint and maybe splinting the extremity. That may be an option to do. Heat to treat the stiffness, so they could either take a hot bath or hot shower to kind of get them moving. The cold helps, as I said before, the inflammation. Exercises, so again, you be mindful that what types of exercises are recommended. Um, no, because it's actually in, there was a question that came, if you splint the joint hands often or as needed, can you prevent swan fingers? Remember, this is actually happening in the joint anyway. So the destruction will still be there, but then it's going to cause limitation of those extremities, if that makes sense. So if you were to put on like a finger splint or a hand splint, then that person would not be able to use those fingers with that splint on. So it depends on how that would work. But PT, physical therapy, occupational therapy would both be, you would need both, because physical therapy would help with the exercises. Occupational therapy devises the orthotics, and they're responsible for the grabbers and things like that. That's what they would need. How to do this at home. How can you still button up your clothes? Here's some things that you could use, fasteners and things of that nature. So it may delay, and I think that's what Dianelle's trying to say, but it's not going to prevent the swan neck, because the symptoms are still going on underneath. So you may not see it as quickly, but they will never eliminate it. It's going to happen regardless. What about, so give me some examples of low impact aerobics that can be done. You're welcome, Jessica. Swimming, perfect. Water aerobics, walking, stationary cycling, riding a bicycle. All of those are good things that they could utilize to keep joints moving. And we've seen folks, if you're in the mall, you actually they go to the mall like 6, 7 o'clock in the morning. They'll open up the doors for them to walk around the mall to kind of get those exercise. I know it's cute. I was like, why are these folks walking? I mean, I'm not hating on them, but it all makes sense. If you have some kind of joint issue, to minimize stiffness, you just keep your body moving, and that should help minimize some of the distress that the individual may have. So, stretching and isometric exercises, those things would definitely help them pick up the speed. That will definitely help them along the way. Hang on a second. Sorry about that. I muted myself. I was like, did I mute myself? So medications we'll look at. Um, it's going to depend on the patient's case. It's going to be a combination of meds though that we can use to help them with their pain. So we look at the DMARD, so the methotrexate. We look at the cyclosporin and the gold salts and things of that nature. And you can use hydroxychloroquine. I did not realize that. So my bad. Also, check vision. What are we checking the vision for? We're using the hydroxychloroquine for the anti-inflammatory process, but why are we checking vision? Retinopathy, so retinal damage, so any type of retinal damage. Biological agents, so we have those MOBs again, those MUMOBs, the tumor necrosis factor inhibitors. So we saw that previously in SLE, they had a specific one that they use. The cenerimod is also for moderate to severe rheumatoid arthritis that doesn't respond to the DMARDs. So our first line of treatment here are DMARDs, okay? And then we look at others, the anti-inflammatories to decrease pain and decrease inflammation, but we got to consider GI upset for those individuals if they're going to take like an NSAID. So make sure we tell them to take it with food. Again, corticosteroids are back. So again, to decrease the inflammation. So you could have dexamethasone, prednisone, methylprednisolone. All of those would be potentials. The immunomodulators, so that can also be used. Abatacept would be an example of that. So there's several things, but glucocorticoids or corticosteroids increase our glucose levels. So up into the 400s. So we need to make sure that we're double checking, blood sugars for that. It is also hard on the skin, meaning it makes it the elasticity, it's thinner, it easily tears. So that's going to be a concern for folks that's on steroids, and whether it's SLE or RA. Surgery, they can have joint replacements, knee replacement, hip replacement. They can have those done. They can have a joint removed and fused together via a bone graft, so arthrodesis. They can have the synovium removed. So there's several surgeries that they could do, but we want to try to eliminate people going through surgeries if we can. Doesn't mean we will never be able to eliminate it. Just means that we're going, we may have to, that may be our last resort, but let's try to start with treating them medically and things of that nature before we get to the surgery, unless it's super bad. So the adalimumab, that's a biologic agent. And so how do they work? What is it? What are those biologic agents going to do? The pain from RA can be significant that it can disrupt sleep. So it depends on the individual. For the biologics, yes, they're basically going to be an immune suppressor or an immune suppressant, or immunosuppressant. That's the word I was looking for. That works to help decrease the inflammatory process, so it doesn't interfere with that. So just kind of have an understanding with some, if you know what the drug does, so then you know why the patient's receiving it, besides the fact that the physician ordered it for them. So it kind of gives you an idea of, hey, if this is an anti-inflammatory, or if this is an immunosuppressant and it has anti-inflammatory process or responses or properties, then this is the reason why the patient would be receiving it. So that way, you know with an assurity why the patient's getting it versus just saying, here's your medication for X, Y, and Z. If that makes sense. All right. So other things, they need to get rest. So rest and exercise, joint support, stay healthy to help decrease those flare-ups. So we want to make sure they're doing regular checks, especially if they're getting the methotrexate. So we also need to give them folic acid to reduce toxicity. Comfort measures, do activities as much as possible, but making sure they're taking good breaks in between to give their body time to recuperate. And that's usually when your body heals anyway, is when you are asleep. So this is why they tell you to try to get at least 7 hours of sleep per night. And we're all making that mark, right? We're getting 7 or more hours per night. I'd love to get 7 hours per night. um we need to do very good skincare, and make sure that we help the patient identify where their deficits are, so that way we can help them get to a better, comfortable, that I'm not going to say they're going to be completely comfortable, but we want to get them to a point where we're getting them to use those extremities. So yes, you have this and this may be a problem, but let's do some things to help minimize or delay how quickly these things onset or progress. Still, don't forget about clot formation as a potential. So when they're hospitalized, we're going to be looking at either the sequential compression stockings or the SCDs, sequential compression devices. So, or they may have actually TED hose on. So those are options. Other things we want to monitor them for is anemia, because we talked about that earlier. So if they have a sudden onset of increase of shortness of breath and they haven't been moving around and they're pale and tired, then we need to treat that appropriately, for which things to that means their red blood cell count's low. um, take the folic acid if they are with the methotrexate because of toxicity. That's what that was related to. So it's to help to reduce the toxicity. All right. So if their red blood cell count is low, then they may need blood. So that may help fix it. Other things: folic acid, iron, B12, and erythropoietin. So look, when they're on the NSAIDs, we talked about the GI upset. This can cause them to have a GI bleed. So we're going to educate the patient about the coffee ground emesis and black tarry stools. So we were just basically asking what were biological agents, Chido, and basically what does it do? And it was an immunosuppressant, is what we were talking about. So it also interferes with the inflammatory process. You're welcome. Okay, so body systems to assess quite a bit. Joints, you still want to check out the heart, the lungs, the kidneys to make sure there's nothing going on there. The skin for sure. Get our lab values, which we've already spoken about. So we've done all that. Make sure we have good IVs, that they're working really well. Do a pain assessment. That's going to be important in that follow up after we give them some pain medication. Um, things to eliminate the stress on the joints. So, raised toilet seats, that would be good to have. So you're going to need someone like OT at home for that. So remember that the skin will tear easily, become thin, and it can easily bruise because of some of the abnormalities in the blood counts or in the blood cells. Look for signs and symptoms of adverse reactions. Where I talked about adaptive equipment and exercises and things like that. This is another multidisciplinary team approach. So OT, PT, case manager, social worker, nutritionist, rheumatologist, all of those are going to be folks that are involved besides yourselves. Dietitian will be nutritionist will be a part of that as well. Questions about RA? Woo, rah, rah. What's your question about the nervous system, Kristen? Or were you just making a comment about the nervous system? That's also included. Yes, you need to assess that as well. And we're going to be looking for, if they are, depressed and things of that nature, and give them time to express any difficulties that they're having with RA. So it's not going to be a real simple path. This journey is going to be long and tedious and drawn out. It's kind of like the individual that has to do kidney dialysis. So that would be another issue. Should a person on glucocorticoids stop taking their medicines? Just just quit? Absolutely not. So that's the other patient education. Otherwise, they'll end up in adrenal crisis. So we don't want to cause that to happen either. So all that educational component is going to be significant and paramount. All right. Trying to see if I missed anything. What if they wanted to do knitting? Can they do knitting? Absolutely. So you have a patient that has, rheumatoid arthritis or even SLE, and they're tired. So we'll say, they get tired in between and they know this is going to be their course of action, but they are concerned about how they're going to, manage to take care of their kiddos. What's the concern that the patient's, expressing to you? So if you have a person that's diagnosed, a woman that's diagnosed with, um, rheumatoid arthritis or even SLE, and they're tired and they're worried about how they're going to manage to take care of their kids when they know they're going to have these periods of being tired. What are they really worried about? Are they worried about the tiredness, or are they worried about their ability as a mother to perform those duties? They're worried about their ability to perform the duties of a mother. They understand that the disease is going to make them tired, but the concern is, how am I going to manage my family if I am having these bouts of tiredness? Does that make sense? So they can have joint pain, anything that they would experience with that, but it's going to prevent them from doing something that they know they have another responsibility for. Does that make sense? So how do they cope with, being tired, and then, managing kiddos. So just say, for instance, now you have somebody that's in this situation and we're doing the shelter in. How are we going to manage that? So I'm tired, my kiddos are home, and I need to do homeschooling, et cetera, et cetera, et cetera. I may have one or two that needs potty training, or I may have one that's, you know, needs more direction than the other two or three or whatever. Does that make sense? So pay attention to your patients and what they're saying. If they already know something's going to make them tired, they want to know, how can I manage my other responsibilities while I'm experiencing the pain, the tiredness, etc. So the plan would be how to manage those kiddos. They know they're going to have to rest, but how do I manage my family? How do I get them to a point to work with me? And for those of us that either have children now, or even though your children are grown, just think about when they were younger, some of the challenges that you had to endure with that. And if you put on or add on a autoimmune disease, that's going to be an issue. Someone said LOL at Kristen. I'm not sure what. Oh, make your older kids work. I love it. So yeah, group therapy, those are good things too, but the person's more concerned about their roles as a mother and being able to perform those duties. And you can suggest things like group therapy, having a second person come in to help you if they can. You can, if you have older kids, you can make them work. That's family support. But folks, make sure that you understand that their concern is about their job. They understand that they're going to be sick or they're going to have fatigue if they are actually, if they have SLE. So, all right. So let's look at our last exemplar, which is multiple sclerosis, and this is another autoimmune disease, which is why it's an immunity. It's another autoimmune disease, but now we have we have a whole nother problem. This is not necessarily an inflammatory issue, but this is definitely a nerve impulse conduction or transmission issue, correct? Tess. I love it. All right, so here what we have going on, this is going to affect the central nervous system, which is the brain and the spinal cord. So we have and your book does a very good job at, showing you the difference between what an actual neuron looks like with the dendrites and the body, et cetera, et cetera, et cetera, and where the myelin sheath comes into play. So it does a fantastic job at that piece. My rendition of it will definitely not come anywhere close to it, by the way. So, don't laugh. Just be prepared. All right. So when you have a neuron, then you have your, this is my little rendition of a neuron. So here's your soma, and then this has the little dendrites here. But then there's a portion there we go, of that actually goes like that. And then we have our other nerve. But I'm going to make this a little bit thicker. So the book does a better job. So you have little channels of axons, or which is your nerve fiber, along this whole neuron. And what ends up happening is your dendrites, which are these little pieces up here, what's their role? They actually receive, is an E here, a signal. that somehow requires an action. So the signal travels down through these dendrites into the body, and then it's going to go here, which is the junction between the somal body and the axon. But this is where the rest of the transmission needs to transpire. So in order for signals or impulses to travel through that axon, they need to be protected or insulated. So when you have axons that are damaged, then the signal doesn't come through correctly. Or it's not strong enough. Now the damage on the axon could be, minimal, minor, it depends. But there's destruction. So basically you have, here's your myelin sheath on the inside, and then you have your insulation part. So this continues to go through, and this is kind of the protector here. So if you start having breakdown along the protected areas, then this nerve impulse will not necessarily go through. The message that's being transmitted will not carry through. So there may be, it starts here and there's a disruption and a little bit and another disruption. So what gets out on the other side, who knows? So that sheath is designed to protect those axons and allow that transmission to happen. And if it's not protected, then we're going to have some issues, distal to that initial impulse. Symptoms, again, they're going to vary from person to person, and they're going to vary in general. So each MS person isn't going to have the same type of MS, and they're not going to, not same type, what I mean by the same structures that are going to be affected. So you can see lesions in different areas of the body, but it's going to affect the sensory and the motor nerves. Again, no cure, another one of those lifestyle changes that folks have to deal with. And this can happen in the brain, it can happen in the heart, it can happen anywhere. Okay. So as we talk about some of the signs and symptoms, then you'll understand why, because that nerve impulse isn't being carried through. So the damaged myelin or the demyelination, that's the part that happens to the myelin sheath. So this, leads to, or this here is the demyelination. So when it's demyelinated, the area that this nerve supplies is will not be stimulated. So that's going to be a huge issue. What are some causes? Number one cause is, again, idiopathic. So that's another problem. And so now there are some other responses, like allergic responses, that they may say may be a reason why. Again, autoimmune. Response of the nervous system. That could be an option. Or there could be things like emotional stress, a bacterial infection, chemical exposure, low vitamin D. Those are some additional processes along with genetics. So it could be genetically driven. Anybody north of the equator is at risk. So that would be North America. Also, Northern European ancestry are more prone. Gender, who does it affect more? Yeah, the last three that we've talked about women, it's all been about women. So this is got to be mindful here. I'm curse, she says. Oh my gosh. Guys have diseases too, so let's, it can't always be them. So yes, more women. Again, 15 to 45 is kind of the common age range, but usually the average is about 29. So that's when that actually when you see that. Um, men do get it, but again, MS is commonly seen in more women. So this diagnosis, it takes time to figure out what's going on. And there's several things that has to be evaluated. There's no one test that says, hey, this is MS. But MRI studies or that can be used to rule out um, or to see if you have any issues. So we'll look at what does. I was trying to clear that. It seemed like it was taking forever in a day. All right, so so when we're looking at diagnostic tools, so we can do an MRI, and what we're looking for are lesions on the MRI because what's happening there is inflammation and scarring. And no matter where it is, those neurons have inflammation and scarring to them. So you can look at signs and symptoms to rule out other diseases. You can also do an LP study. What's an LP? Curve. LP is a lumbar puncture in True Kristen. They're going to look at the oligoclonal bands. They're going to look at those. And that is actually specific to MS. Okay. There's some kind of electrical study that they can also do where they will elicit an electrical signal and wait for an electrical response. So they may do that. They'll assess the response after the signal's been sent. How did the neurons respond to it? So basically, did they receive it? That's another option. So kind of backing up a smidgen, we kind of talked about the patho. We kind of talked about people that are more prone to develop it. Yes, it is. It's called the evoked potential or electrical potential, something like that. The evoked potential study, I believe, is what it is. So looking at history, things that they may complain of is, fatigue, and that's going to be seen in the majority of the patient, dizziness, vision problems like double vision or gaze. One of the first signs is sensory impairment. So those will be things that the patient may complain of. And there is an array of signs and symptoms. So let's look at that. So signs and symptoms. So fatigued, extremely fatigued. They're just drained. So that's one. That they can have speech issues or speech difficulty. And that's known as dysarthria. And that will be an early sign. Another early sign would be spasms, and they'll be very painful. Patient's very clumsy. So here, this is going to be a safety issue for falls and injuries. So their coordination issues. Dizziness. From a visual standpoint, they could have that optic neuritis. And here, this optic neuritis would consist of the double vision, blurry vision, seeing dark spots. They can also have incontinence of the bowel and bladder. From the bladder standpoint, the nerve isn't stimulated, so they may not be able to hold their urine, or they may have nocturia, or the bladder may be overactive. They can have urinary retention, and if they end up with urinary retention, because they can have the opposite here, so they can end up with urinary retention, and then now we would have to be concerned. Our concern here would be UTIs. They can also have constipation. So I'll put here. What's a sensation sign that they may have? What is that called? Hold on. Okay, the one for sensation would be you have the patient stand the Romberg sign. That's the one I'm looking for. So they could have the Romberg sign. That was my whole finger, literally. So the patient stands with their eyes closed, their feet together, and if they can't hold their balance if they can't hold their balance, that's a problem. Or if they start to sway. So here, basically eyes closed and feet together. So this is positive if patient loses balance or starts to sway. And that'll be side to side. Ricky, you put a sign up there. What is that sign? You put Lhermitte's sign. What is that? And then FM, I'm not sure who you are. Tell us what the Utah sign is. Electrical shock feeling. Okay. So when they move their head, it feels like they're getting an electrical shock sensation down the rest of their body is what that sign is. That would be the Lhermitte sign. The Utah sign is when you put heat or add heat, then it makes their signs and symptoms worse. That would be the Utah sign. So the things that I listed here are your early signs. There are other signs that the patients have, like difficulty swallowing, being depressed, mood swings, difficulty problem solving or focusing. Those are also additional signs and symptoms that the patient may have that are not your early signs, but are still signs and symptoms that the patient will display. So, just like all of the other two exemplars we spoke about for RA and for SLE, there's a plethora of signs and symptoms that they can have. Some things are pretty specific, like the discoid skin lesion or the malar skin lesion. Those are things that are not present in other conditions. So you have some things to eliminate the the difficulty in saying which one belongs to which. But they have the sign that you normally see, or you see a trio of things that happen in MS, which is the dysarthria, which is the difficulty speaking or formulating the words, the nystagmus that they'll see, which is part of the optic neuritis issue, and the intention tremors. So they could have tremors as well. So that's usually one of the bigger things that's also outlined for an individual with MS. Lab values. What lab values are we going to look at? Do we have any that we can identify? Most of it's all based on the physical signs and symptoms, correct? And then getting x-rays to see what's going on, like that MRI, to look for those lesions in the brain. Because if they have lesions in the brain, cellular lesions in the brain, more specifically, and let me just ask, for all these coordination issues, ataxia and things like that, which brain area of the brain is primarily affected? Was that the cerebrum, the cerebellum, or the brainstem? It's going to be the cerebellum or the cerebellar. So that's the reason why they're having the coordination issues, because that portion of your brain is responsible for that. But they can also look for plaques on a CT, but they're still looking for those inflamed neurons, those scarred neurons. And when they say inflamed and scarring, they're basically talking about lesions. They call those lesions. So they need, if they're constipated, then we need to, encourage fluids and a high fiber diet. But this is basically supportive care. We're going to treat the signs and symptoms, treat the exacerbations, do physical therapy, occupational therapy. Now we need to add in speech therapy because of the dysarthria, manage the stress, and then we can start looking at medications. So we have disease modifying agents, so the DMARDs, so interferon B, or interferon beta 1A that we could use, or 1B, right? So Glatiramer, we can use that one subcutaneously as another DMARDs that can be used. What else can we use? Because there's a whole host of those that we can actually utilize for those patients that are DMARDs. Yep. Anavex would be another good one. The anti-inflammatories, so your glucocorticoids, methylprednisolone, your Decadron or dexamethasone, again, to reduce the inflammation. We can do immunosuppressors, so that we've seen before, the cyclophosphamide, we've seen that, the methotrexate, we've seen that. Baclofen is another good one to help with muscle spasticity. We can also use some benzodiazepine as a secondary Lyme agent, which will be your clonazepams or diazepams. Diazepam is that Versed or Valium? Valium. Okay, so we have Haldol if they're having psychosis, and we can also look at giving them, if there's no evidence of actual effectiveness, but looking at chronic fatigue. They don't have any information to say this is effective, but they're giving them the amantadine to help with the fatigue. They can use TCAs, tricyclic antidepressants, to for pain that's related to the demyelination. Gabapentin is another one. That gabapentin is actually helps with neurologic pain or neuropathies, but it's more for nerve pain itself. So that's you may see that given quite often. There are three categories before we get to the nursing interventions completely. There are three categories of MS. What are they? R&R, is that rest and relaxation? I'm just playing. So relapsing and remitting. So let's talk about that one real quick before we get to the other two. This is R&R, or relapsing and remission, or remitting, however you want to call it. But basically, they have a relapse, and then they have an acute TAC or an acute exacerbation with full recovery and no lasting disability. There's no increase in the disease process in between the attacks. 85% of the people that are diagnosed with MS end up with this particular one, okay? Then you have someone put PPM, which is primary progressive. And so with your primary progressive, this is where you have a steady progression of MS, and in between the symptoms, there's minor recovery or there's minor worsening that happens with that individual. And this could involve different areas of the brain and the spinal cord from other forms. The secondary progressive looks at, the pattern is pretty clear-cut relapses and recovery, but in between the attacks, the disease progressively gets worse. Then you have progressive relapsing, where there's just a steady decline or a steady worsening of the condition from onset, and it continues to have these acute attacks, and that's the least common. So your most common is the relapsing and remitting. Your secondaries would be the primary progressive and secondary progressive, but here you start noticing in between the relapses and recovery that there's a change in the patient's condition where the disease is moving or progressing through. So that chronic fatigue is definitely going to be alarming or concerning. All right. What type of interventions do we want to do for these folks? And this will probably round us out to the 12 o'clock hour. because there's quite a bit. I mean, you have a tired person. How about clustering care? How about that one? Not to tire out the patient. Safety, very good one. Okay. Use of the TED hose or SCDs. Heat application to, and you have to be, careful, making sure you check the skin and making sure that that heat application isn't too hot because you don't want to burn the skin. Remember, it's going to have issues. Exercise just short of fatigue. True, just don't go all out on the exercises. Making sure they take the medications, we give them the education about that. Self-esteem and dependence, we're going to talk about that. Assist with elimination patterns, absolutely. Assistive devices, yes. So these are all things that we can do to help manage the patient better. And, kind of a general rule of thumbs of things of, don't tire yourself out. You have to kind of space things out. Making sure they know that some of the medications they cannot stop abruptly. So avoid stress and fatigue and infections. Nutritional management and making sure they have a good fluid intake. You also may look at addressing sexual dysfunction in men. That's usually one of the topics. If it's women that have to talk to a man about that, it's like, I don't want to talk to him. And vice versa for the guys. If they have to talk to a woman about sexual dysfunctions, it's like, I don't want to do that. But you may be the only person that person will actually may feel comfortable talking to. So you may have to have that uncomfortable conversation. So another multidisciplinary approach is what we're going to be looking at. Get the family's involvement, let them know what this treatment's going to entail, and you can help the patient out with that and what it's, they're going to need a lot of assistance, especially when they're having those exacerbations or flare-ups. And assess their understanding about medication. So make sure we educate them appropriately. And I know a lot of times, in clinical, you're able to kind of click on the medication and it'll tell you about the signs and symptoms. But sometimes those signs and symptoms were not necessarily related to the issue the person was having. And all of the medications that we take can give us GI upset. But if I have someone that I'm giving like a cardiac med to, then I'm going to talk about, getting up out of the bed really quickly because I don't want to drop my, I don't want to have an orthostatic hypotension event. So it's making sure it matches what's going on. Avoid foods with liquid consistency if there's dysphagia, absolutely, to eliminate risk of aspiration. So that would definitely be a problem because they do have difficulty swallowing at some point. That will become an issue. How would you know? The patient won't be able to manage their secretions. So just the normal saliva they have in their mouth is going to be difficult for them to manage. So any questions? We have 4 minutes. So you guys are all ready for the test. You're like, woo woo, yes, we got this, right?
I have a question, Ms. Hudson.
Uh-huh.
I was doing some PrepU questions about TB, and there was something about isolation precautions for home care, and I chose to teach about that, and then it said that it wasn't necessary. So I wasn't
right.
sure.
For the folks that, if they're at home, then so say for instance, and I'm not putting this on everybody, but say for instance, you are, and I'm going to go full disclosure, somewhere along the line in my clicking, I froze recording. So I apologize for that. However, if you have a question about whatever we talked about, post that. I don't know exactly when this happened. I just looked up and I saw that recording was frozen, and I'm irritated. But moving on. To answer your question about that, if you have a person in your household that tests positive for TB, and we talked about this last on Wednesday, they're not going to self-isolate everybody in their place because what they're going to do is treat the family members prophylactically if that person has active TB. Does that make sense?
Yes.
So now what they may, they're not going to do the self-isolation because there's no need. They all have to cohabitate in the building together. Now, if you had like a side-by-side duplex and one person could live on one side of the house and the other person could live on the other duplex side, okay, but everybody didn't have that. So if they're in that space together, then everyone's going to be on medication. So the person with active TB and then the folks that will come in contact with that individual, they'll treat them prophylactically. Rodolphine, you are correct. We do have inflammatory bowel disease, specifically ulcerative colitis and Crohn's. So, if you have, I think that's a little bit more easy to understand and how that happens, and they have a lot of information out there on it. That's the reason why I chose to look at the other ones. Now, if you have a question about inflammatory bowel disease, and specifically ulcerative colitis and Crohn's, I'll be more than happy. Just shoot me an email and I'll be more than happy to answer that. So there is enough. There is a one more exemplar.
Okay, regarding our, that's what I was going to ask too, about scratch paper.
I did address the scratch paper one earlier. I'll readdress it again.
Sorry, I was
no,
late.
You're fine. No worries. So scratch paper physically on your desk is a no. There is a whiteboard that you'll be able to use within Exemplify for scratch paper. That was the decision. I'm going to leave it at that. That was the decision that was made. So, because if you allow scratch paper, then there's no way for them to know that the scratch paper, and this got a little convoluted, but doesn't have additional information on it, etc. And we can't see it. So I'm sorry. No, there'll be a calculator provided for you, Miss Emily. There'll be a whiteboard that will be given. It may not have been in the practice test, but in order for the whiteboard to be given, there's a specific button that needed to be selected. So for the practice test, we just left well enough alone. But for the test, it would be a whiteboard. Same amount of time on the test to complete. There may be a couple of extra minutes just for you to navigate through the whiteboard component. But overall, it's going to be about between 90 and 95 minutes is what you're going to have to take the test. It'll be 60 questions. You'll get probably about an extra 5 minutes on it. Any other questions? 10 o'clock. It'll be made available to you at 10. And if you are an accommodation student, your time still starts at 10. And it will go until whatever your allotted accommodations are. No, you do not. You need to be in uniform. Personally, it's very difficult to enforce that process. And honestly, just long as you're not in there naked or anything obscure, I'm fine with it. So, don't be like my friend who only had the top half of his, he was dressed on the top half and he had to stand up to go get some paper or something like that, or he was doing an interview, by the way. And he was like, oh, I left that paper over there. And he stood up and he was in his underwear. So I was like, who does that? So this is why I say, you need tops and bottoms because you never know when you need to get up and you're on camera, whatever. And then he said, I think I may have dug up my nose. I'm like, you have got to be kidding me. And so needless to say, he didn't get that job. The government is watching. With all this online stuff, I can't say they are not, but either way. So this was probably it'll start downloading once I end the meeting, and I will post it to the course board as soon as it does. So it shouldn't, I'm hoping it doesn't take any more than, 30 minutes because YouTube, they're going to actually visualize it to make sure there's no, sex trafficking, et cetera, et cetera, et cetera. So they have to clear their house and then I'll post it. but I did one of these last night or yesterday, and it was up and posted within 30 to 45 minutes, so it didn't take that long. The holdup was YouTube. It was already downloaded, but it was them to approve it. All right, guys. If nothing else, then we will see you Monday, and then we will start on intracranial regulation, and it is quite a bit of that to do. There's all kinds. To help supplement that material, I found a very good PowerPoint that you will use in clinical for post-conference. So it'll help solidify some of the things we're going to talk about already in class. We'll see you then. All right, bye guys.